Hi everyone, Holly Hood here again. We hope you're enjoying the sessions on our first full day of conference. We've had a lot of great ones. All right, I have another joke for you. Are you ready? Did you hear about the one in the little mountain? It was hilarious. Get it, Hill? So the session that you're about to watch is called Autoimmune Disorders with Dr. Brooks. He has a wealth of knowledge to share with you, so we hope that you learned something. And again, don't worry if you miss a session. They'll be recorded and available after the conference. If you have any questions, go ahead and type them into the chat box during the presentation, and one of our staff members will get with the presenter afterwards. Please also remember to mute yourself and turn off your camera during the presentation. We will also pop a few links into the chat box, so if you're interested in more about our silent auction, merchandise, our family table touring event, please check out that as well. Before we get started, I wanted to share a little bit more about Dr. Brooks. So Dr. Brooks is a professor of pediatrics and internal medicine at the University of Texas Health Science Center in San Antonio. He is a specialist in allergy, asthma, immunology, and rheumatology, and has collaborated with the Chromosome 18 project for the last 5 years. Dr. Brooks has conducted biomedical research for more than 30 years and has published over 50 peer scientific manuscripts. He has research interests in environmental effects on airway inflammation and the mechanisms of immune disorders. So without further ado, let's get started with the presentation, Autoimmune Disorders.
So I'm Ed Brooks, and I'm going to talk about, well, the title is Autoimmune Disorders, although it's going to be a bit broader than that. We'll talk about immune disorders in general in the context of chromosome 18 alterations. This project has actually been going on for some time. Over the past 10 years, the Chromosome 18 project staff has conducted a number of surveys, including immune disorders, and specifically in things like allergy and immune deficiency, as well as autoimmunity. And I want to focus a bit more on autoimmunity. I've presented these results and part of these results over the last couple of years. And in general conclusions, that there are high overall rates of immune dysfunction in chromosome 18 alterations. And the purpose of the surveys is to determine the impact of chromosome 18 deletions and duplications on the occurrence of these immune disorders in a more specific way, not just a general way. And alterations often result in loss or gain of specific groups of genes, right? And so we interpret the results as a gene dose effect, in that there's less total loss of these genes. It's just loss of half of them. And that's sort of the more typical in the 18p and Q minus. So I'll talk more about how that might impact some of these conditions. So in overall disorders of the immune system, we can kind of categorize in three broad categories of immune deficiency: having too few antibodies, or a weaker immune system in which infections seem to dominate the picture. Hypersensitivity, which are quite common. It includes common allergies and asthma, things of that nature. We think of maybe too aggressive an immune system against relatively innocuous environmental agents such as pollen and pet dander. Autoimmunity, we tend to think of the immune system as dysregulated in the sense that it doesn't have self-tolerance, and it sort of attacks, if you will, our tissues, whether they be joints or the eyes or the skin or other organ systems, and causing damage and inflammation. So in regard to immune deficiency, we're talking about kids with frequent, severe, and prolonged infections with various organisms, various viruses, fungi, bacteria, and parasites. They tend to get a lot of ear and sinus infection, possibly pneumonia, meningitis. And but the rate of these is really very small in the general population, less than 10% incidence. And that's sort of being a little bit magnanimous in that, the most common immune deficiency, single gene immune deficiency, is the IgA deficiency. And many individuals carry that problem, but don't necessarily have a lot of immune deficiency. In other words, manifestations of it, they seem to be fine. That said, some of the other alterations in immunity that cause immune deficiency, or in some are extremely rare. And we usually treat these disorders with, routine antibiotics and sometimes antibody replacement. And in the more extreme examples, a stem cell transplant or bone marrow transplant. And so overall, and I've shown this information in the past, is that the rate of these disorders collectively, around 16, 17%, are much higher than what we might expect in the general population. And when we look across the various chromosome 18 alterations, there's not a whole lot of variation. There may be an increase in the 18q minus population in comparison to the 18p minus or ring 18. And so that's basically how I will talk about this, is not in terms of the general population, but in terms of the, the population of chromosome 18. And so comparisons like this are quite important because the 18q minus group has a full complement of the 18p genes and vice versa. So it's a good, if you will, a kind of controlled comparison where you're missing, one arm of this chromosome 18. And so in that context, I would think, well, that's sort of a significant finding. Hypersensitivity disorders like asthma, allergies, food allergy, and eczema all sort of cluster amongst, in the general population. We know quite a bit about the genetic variations that we say polymorphisms that may predispose an individual. And as many of us know, that these conditions run in families, and so the genetic component is fairly clear. That said, in the general population, there's a substantial increase in these disorders over the last 20, 30, 40 years. Celiac disease is quite different. It is a hypersensitivity against the wheat protein gluten, and it has a different type of manifestation. It doesn't seem to occur with higher frequency in people with otherwise allergic disease. So in the general population, sort of an upper limit of that is that, people have there's 25 to 25% of the population that may have one of these disorders. So it is quite common. And we treat it with, avoidance of the offending environmental agent, whether it be pet dander or gluten and wheat. And certain medications certainly are beneficial. And there's quite a bit of experience, I'll say over 100 years of experience with immune therapy, meaning like traditional allergy shots and drops, the under the tongue drops we call sublingual immunotherapy. And it's quite effective and essentially in that, and I think it's a nice example of how we can take environmental agents and desensitize or make people tolerant of these environmental agents and sort of re-educating the immune system. And I guess it begs the question, well, why did the immune system not become educated to these common environmental agents in early childhood? And I'll talk more about that concept because it kind of is pervasive across all immune disorders. So in looking at the population, I think we were quite impressed that the 18q minus group had a much higher prevalence of these types of disorders compared to the P minus, and the ring 18 was very similar to the P minus. So I would think that's probably a significant association, which kind of makes me think about what is on the 18P arm that might be important, and I'll go through that in a bit. Autoimmunity, which I want to spend the rest of the time really talking about autoimmunity. And this is just an example of type 1 diabetes. It's an attack on the pancreas, and in juvenile arthritis, there's an attack on the joints and sometimes the eyes. Systemic lupus is more of a systemic problem, which many organ systems can be affected. But again, it's thought to be primarily mediated by autoantibodies. The body makes these antibodies, and some of them are quite common that we all carry, but in this condition, they're much higher and they actually cause disease. Thyroid disease is actually somewhat of a common disorder, Hashimoto's, thyroiditis, etc. And then the skin disorders such as vitiligo and alopecia, as well as psoriasis, are things that attack either the skin cells themselves or the hair follicles or the pigment related skin. So again, these are immune attacks on specific components within the skin. And then inflammatory bowel disease, such as Crohn's disease, it's a dysregulation of the immune system in the gut, and it causes fairly severe inflammation in the gut. But again, we categorize it as an autoimmune condition. So more specifically, we've looked at various conditions, quite a few actually, in the more recent survey that was conducted in 2019. So we see inflammation in the joints and occasionally the eyes, and nicely, most of these subtypes of juvenile arthritis resolve in childhood, and the prevalence overall in the population is quite low, much less than 0.5%. That said, we are seeing an overall increase in the prevalence of JIA, as we call it, in the general population. And I'll mention what the theories are behind that, because it's similar to allergic disease. We've seen a tremendous rise in allergic disease over the last 30 years. So when we look at these populations, once again, the 18Q- population appears to have a twofold increased prevalence in this. And this was a smaller survey that we had conducted, and we only had 11 cases that reported this particular condition. So the numbers are small, and whether it's statistically significant, it's hard to say, but it is trending similarly as some of the other disorders I've just mentioned. So this was our more complete survey, and this information, have a few more cases, but this information seems to bear out. And the Ring 18 group, although it's a smaller group, had quite a few cases, had 3 cases. So, that comes out as 11% prevalence rate. So either way you look at it, all of these rates are greater than what we would expect in the general population in all of the chromosome 18 groups of patients. Despite that, we see a difference among some of the specific gene alterations. Regarding skin disorders, the 3 disorders that seem to pop out in the surveys most commonly are psoriasis, alopecia, vitiligo. And these conditions are, result in inflammation of specific skin structures. And of course, we can treat particularly the psoriasis with anti-inflammatory medications that are quite effective, and only partially effective in alopecia and vitiligo. And those disorders have more of a cosmetic impact on the patients. And so often, rather than expose an individual to side effects of immunosuppressive therapy, many individuals choose to not treat that, or treat it just with topical therapy, which is less effective. So in part, it's not that as treatable, but in part because the long-term effects of both of those conditions are mostly cosmetic. And that said, this particular disorder, we see a much higher prevalence percentage-wise in the 18P. So this is the one example in which the other side of the chromosome seems to be more important than the Q-. The others, as I've mentioned, the Q- seems to have a higher prevalence, and there may be some potential explanations for that. Regarding the gastrointestinal disorders, like Crohn's disease and celiac disease, again, they cause inflammation in the gut, and the medications that we have available now are quite effective. And of course, dietary restrictions such as avoiding gluten seems to be quite effective. And we're back to where the 18Q- population has about a twofold increase over the P-. And again, the rate of these overall seems to be much higher, other than in the trisomy, which we didn't have any cases, but it's a smaller population. Regarding the thyroid disorders, there were 30 individuals who reported some sort of thyroid disorder, and the most common are going to be what we call Hashimoto's thyroiditis and Graves' disease, which are autoimmune diseases. There can be other thyroid dysfunctions that are not autoimmune. And so without specific testing of those individuals for autoantibodies, et cetera, sometimes it's difficult to know for sure. And in these cases, between P and Q, there doesn't appear to be any difference. And in the ring 18 subjects, again, a smaller population, but seem to have a much higher proportion. So regarding these surveys, there's high overall rates of immune disorders. And I'm going to talk about that in the next slide. But there are certainly higher rates of immune deficiency, hypersensitivity, arthritis, and celiac disease that seem to segregate with 18Q minus fairly consistently. And we've done this over a couple of different surveys and increased numbers. However, there's a higher rate of psoriasis and some other skin disorders in 18P minus, and a higher rate of thyroid disease in ring 18. And so, and a lower overall rate of all of these disorders in tetrasomy 18. So how do we interpret this? Again, these just survey information, and it's not as accurate as doing specific laboratory testing and really honing in on the expression of specific genes that might be interacting with these particular disorders. So let's talk about some of the genes that I've pulled out over the years and done some background investigation as to how they may or may not be involved. And so one of the ones at the top of the list is what we call CD26, and it's on 18q22.2. And this gene is quite important in immune regulation, and particularly has been associated with regulation of viral infections and autoimmunity. And now, of course, some of the basic research in all of these genes, or some of them, has been with animal studies in which they knock it out, but they're knocking it out completely. And so they get a good idea of if you're missing this gene completely. So it doesn't tell us exactly if these particular genes have a gene dose effect. In other words, if you knock out one arm, there's effect. In fact, I'm old friends with one of the scientists who did some of these animal studies where they knocked out the gene. And I asked him, they don't report usually the heterozygous mice, but I asked him specifically, and he said they don't recall seeing anything in those mice, but it was the mice that it was knocked out completely. And so at least in animals, so there's no obvious effect, but again, this wasn't carefully studied. The next gene, and actually I'll skip down to the bottom because I'm going to put this in terms of importance, and maybe the TCF4 gene should have been at the top because it is well known to be the mutation in Pitt-Hopkins syndrome, and it's essential for the development of what we call plasmacytoid dendritic cells, which are very important in guiding immune responses. These in deleted mice with this TCF4 gene deletion have a severely reduced interferon alpha, which is one of those biological molecules that's very important in defense against virus infections. And so those individuals, at least in the animal studies, have susceptibility to a certain family of viruses, not everything. So it's sort of a, if you will, a targeted defect that they might have, and how humans might respond in this, hasn't been really carefully studied, although they certainly have increased frequency of certain types of infections. The other gene on the 18q is the SERPIN-B2. And what that is, it's been associated with, it's called the plasminogen activator inhibitor 2. And it's a regular of what we call the kininogen system, which is involved with complement and other kind of immune actions. And it's been implicated in a condition known as hereditary angioedema. Now, we didn't ask specific questions about these. This is sort of a very rare disorder that can occur in individuals that have the dominant defect is in another gene. but this one is just recently recognized. And they, you know, the angioedema, they get swelling episodes and certain types of skin rashes, not necessarily immune deficiency, if you will, not increased infections, not necessarily increased allergy, and not necessarily increase in autoimmune conditions. So this one is sort of a wild card, as I'm not sure, but we may in future surveys add some questions regarding this particular disorder, the symptoms of this disorder. Now on the P side, there's two genes that seem to have some interest, and one's called the AA1 or alopecia areata 1, and it's on 18p11. And there's, as you might guess, a genetic association with alopecia universalis, meaning complete loss of hair in the entire body. And then another gene, aptly named psoriasis susceptibility gene number 10, is highly associated with psoriasis. So how do we kind of put this together with the information that we've gathered in our surveys? Actually, let me skip that one. So the second line there is increasing rates of immune deficiency and hypersensitivity and autoimmunity in 18q minus. And the interpretation on the backdrop of the genes might be due to haploinsufficiency, the word we use that I've misspelled, apologize, of the CD26, SERPIN-B2 or the TCF4, and more specifically the CD26 seems to be, and the TCF4 might be more important in those disorders than the SERPIN-B2. And on the P side, they have increased rates of psoriasis and alopecia, which might be due to, in part, the psoriasis and the alopecia genes that have been associated in the general population. And then, you know, so again, thinking of gene dose effects, so if there's a loss of function of some of these genes, it's possible it may result in some dysregulation of the immune system. There's overall rates of immune disorders, reduced rates of in tetrasemy 18. And once again, it's sort of a wild guess that they have more of the complement of genes. Could that have an impact on preventing or a protective effect on? So having, extra of these genes might have a suppressive, if you will, effect on some of these immune disorders. Very, very highly speculative, but that's the nature of this. And this is sort of the platform upon which we begin to try to answer those questions in a more scientific way. And I'm going to go back up to one of my main points, and this is kind of to explain why do we see such high rates of immune disorders in general in this group of patients. And so what we have learned is something called the hygiene hypothesis, that we are too clean. And many of you may have heard of this. And the basis of it is there's a critical role for microbial exposure, for immune development and persistence of, or balance, if you will, of the immune system. And has been evidence for many years that there's reduced diversity or fewer different types of these, the microorganisms in the intestines in immune-mediated diseases, such as particularly allergic disease. That was sort of the early work that was done. And more recently in juvenile arthritis, there are some reports. And I think this is sort of a becoming more commonly accepted explanation or theory behind why we're seeing higher rates of immune regulatory disorders in general, in the general population, and perhaps in this population. So we kind of have to ask ourselves about what is unique about the chromosome 18 population that might lend themselves to reduced microbial exposure, or, if you will, living in more sterile environments, et cetera. And this opens the sort of the window for, and many have heard of probiotics, which have sort of a modest effect in some areas, perhaps a more, in some ways difficult, but is what we call prebiotics, which simply means you want to your diet should contain things that promote the good bacteria or the good microbial environment in your intestines. And sort of an extreme example of microbial therapy is what we call fecal transplant, which has been shown to be quite effective in disorders in which there is an overgrowth of something called C. difficile infection because of overuse of antibiotics, and fecal transplants quite effective at correcting that. You're replacing the microbiome, if you will, with a normal microbiome. And so those studies in other immune disorders are also beginning to show some promise as well. I'm going to show, I hope, a little YouTube video here that outlines this concept regarding the hygiene hypothesis, and more specifically how it might relate to disorders in the intestine. Let's see, hopefully I can get to it.
We have microbes all over us. They outnumber host cells by about 10 to 1. It is clear that the microbes that we live with, that are in our body and on our body, are very important to our health. We're interested in how microbes influence the immune system, particularly the immune system of the gut. There are approximately 100 trillion microbes in the oral cavity and in the small and large intestine. In this project, the question really was, are they unique? We have microbes all over us. They outnumber host cells by about 10 to 1. It is clear that the microbes that we live with, that are in our body and on our body, are very important to our health. We're interested in how microbes influence the immune system, particularly the immune system of the gut. There are approximately 100 trillion microbes in the oral cavity and in the small and large intestine. In this project, the question really was, are they uniquely qualified to live on us, or could they be substituted by microbes that come from another species? We couldn't take the microbes out of humans and put another set of microbes in. Instead, we did it in the mouse, where we started with germ-free mice. These mice truly have no microbes on them. We actually check them every week to make sure that just in our handling of them, they don't acquire bacteria. So now in each isolator, we had mice colonized with either human or mouse microbes. We really wanted to see if there was a functional deficiency in the case of mice with human microbial species. So what we did was we challenged the mice with Salmonella typhimurium. It's a pathogen that causes the intestine to get inflamed. What we found was that their immune systems were not functioning in full force, but these mice could withstand infection when colonized with mouse microbes. To examine this further, we colonized mice with rat microbial species, and actually the rat microbes were no more useful to the mouse than the human microbes. These studies provide evidence that microbes, and in our case humans, have co-evolved over eons to have a beneficial relationship to each other. This also fits in with the hygiene hypothesis. Our clean environment may affect the microbes that inhabit us, that provide resistance to infection and perhaps to other diseases as well. Qualified to live on us, or could they be substituted by microbes that come from another species? We couldn't take the microbes out of humans and put another set of microbes in. Instead, we did it in the mouse, where we started with germ-free mice. These mice truly have no microbes on them. We actually check them every week to make sure that just in our handling of them, they don't acquire bacteria. So now in each isolator, we had mice colonized with either human or mouse microbes. We really wanted to see if there was a functional deficiency in the case of mice with human microbial species. So what we did was we challenged the mice with Salmonella typhimurium. It's a pathogen that causes the intestine to get inflamed. What we found was that their immune systems were not functioning in full force, but these mice could withstand infection when colonized with mouse microbes. To examine this further, we colonized mice with rat microbial species, and actually the rat microbes were no more useful to the mouse than the human microbes. These studies provide evidence that microbes, and in our case humans, have co-evolved over eons to have a beneficial relationship to each other. This also fits in with the hygiene hypothesis. Our clean environment may affect the microbes that inhabit us, that provide resistance to infection and perhaps to other diseases as well.
Okay, so I think the take-home message is there's a lot more work that we need to do, and I'm optimistic.
Good grammar and spelling are important, but if you want to
Sorry
write
about that.
essays that inspire, messages that forge
YouTube. Let's see. Okay. Let's see how this works now. Anyway, it gives me optimism that there may be some simple approaches to prevention of some of these conditions and treatment, perhaps using these theories and these concepts and, if you will, in a more modern way. I mean, short of go roll the baby in the dirt, so that they get, a good microbiome and kind of reduce the use of broad spectrum antibiotics, which we're already doing. But I think it sort of gives us a different way of thinking about these things rather than simply attacking directly the inflammatory response that we see in these immune disorders. So I mentioned this a little bit. Overall, there's increased rates of immune dysregulation in the total population of chromosome 18. And I'm suggesting that it's possible that it could be due to environmental rather than directly genetic effects. And there's increased rates of immune deficiency, hypersensitivity, autoimmunity, et cetera. In 18Q, we kind of talked about that. Increased rates of psoriasis and alopecia in 18P, and reduced rates overall of tetrasomy 18. And whether that is the influence of the genetic influences, I think that's reasonable. And one of the things that we say often in this field is that the genes load the gun, but the environment pulls the trigger. So even with a certain set of genes that we've inherited, there may be environmental treatments, if you will, or lifestyles that may be beneficial for reducing the risk for some of these conditions. So I want to thank the entire Chromosome 18 team, Dr. Cody in particular, and especially the families who participated in these surveys. It was invaluable information, and I'm sure you'll be asked by the team for more efforts in the future. Thank you so much.